Yeah, good morning, everyone. We'll try to cover most of the transplant emergencies in 15 minutes. It's going to be a
We're going to pick three. We're going to pick
challenge. All right. So we'll discuss the common morbidity and mortality related to heart transplant with a focus on arrhythmias, infection, rejection, and if we can get to cardiac allograft vasculopathy and early post-op complications, that'll be great. So, just to begin with, there are two techniques by which a heart transplant is done surgically. One is bicaval, and the most common one is bicaval. And the earlier technique used to be biatrial, where the right atrium is sutured on to the right atrium of the recipient, and the left atrial cuff is the same in both biatrial and bicaval. In bicaval technique, the superior vena cava and the inferior vena cava are anastomosed. So the right atrium, which comes from the donor, is relatively preserved in bicaval technique. So the reason this is important is because there is a definite difference in the post-transplant complications in whether patients undergo bicaval or biatrial technique. The advantages of biatrial technique is that it's simple and the ischemic times markedly is a little bit less. But the disadvantages are that because you have a right atrial cuff, so there are chances of damage to the sinus node is more, and also you end up creating a substrate for atrial tachyarrhythmias and bradyarrhythmias. So that the incidence of pacemaker is much more in biatrial technique compared to bicaval technique. There is some suggestion that there is a signal towards better long-term survival in patients with bicaval technique, but that has really not been reproduced in many studies. So one of the major complications that you will see when you're taking care of patients in the immediate post-operative period is bradycardia. It is sometimes seen in late post-transplant patients as well, the way to sort of go over this is to look at whether patients are symptomatic or asymptomatic. Initially, if the patients are asymptomatic, then should give a trial with medications, especially if we can get by with terbutaline, which is oral, or if we have to use any IV medications like isoprotenolol or IV inotropes. And if you have persistent asymptomatic bradycardia, then consider a pacemaker. Now, bradycardia can be one of the presenting features of rejection. So if you have sustained symptomatic bradycardia with a drop in ejection fraction, then you have to consider that the patient may be rejecting and consider endomyocardial biopsy. And if they do not have rejection, then consider putting in a pacemaker in these patients. So the big thing about transplanted hearts are they are de-innervated. And about 70% of the patient hearts reinnervate at the end of 5 years, but the degree of reinnervation is very variable. So you cannot really predict who completely reinnervates and who does not. So the resting heart rates of most heart transplant patients are between 90 and 110. Which is why bradycardia in these patients is defined as a heart rate of less than 90. So because they are denervated, their symptomatology when it comes to having any heart-related issues is going to be very different. So they are not going to have as much angina as compared to somebody with a native heart. And these patients are uniquely dependent on the circulating epinephrine, circulating norepinephrine. So using systemic agents which would depress these systems will have a unique effect on the heart. So just to go over some of the medications like we just discussed, which have an effect on the heart rate in native hearts and look at how they affect the transplanted heart. As you can see here, atropine and digoxin really don't have much of an effect on the transplanted heart. Of course, this is presuming that all these hearts were still denervated. So, the other thing to really look at is use of adenosine. So, if you look at ACLS in patients who have SVT in a native heart, the first line of therapy would be to give adenosine. you should not really almost never give adenosine in transplanted patients because you will, see marked bradycardia and sometimes asystole, which can last for a few seconds. And believe me, I mean, you'll really feel that that sense of impending doom when you're, doing that and standing in front, in front of a patient after you give adenosine. So. And the other things to really look at is when you're using beta agonists like terbutaline or isoproterenol, you are going to have an exaggerated effect because they do not have a vagal effect, so it is unopposed beta action that you will be seeing. And again, the use of beta blockers, this is kind of controversial. I would say, the recent studies which have been, there are at least 2-3 reports out of Europe, which have looked at the use of carvedilol in long-term transplant outcomes, and use of carvedilol in long-term transplant outcomes, there is actually a benefit. So our algorithm here has been that in the first 6 months, we do not use much beta blockers, but after the first 6 to 12 months, once patients have been doing well, then it is reasonable to consider COREG if the patient's persistently hypertensive. So now switching gears and going into some tachyarrhythmias. Atrial flutter is the most common tachyarrhythmia in these patients. Average incidence of about 15% in the immediate post-operative period. Most often it is just, related to the inflammation that's associated in the post-operative period. But if you get it in the perioperative period, about 15 to 45 days, you have to have a low index of suspicion for rejection and consider a biopsy in these patients. Now again, non-sustained ventricular tachycardia, fairly common in the immediate post-operative period, and most likely associated with the, the cold ischemic time and the ischemic injury which occurs with a transplant episode. But if you have symptomatic non-sustained ventricular tachycardia or sustained VT, you have to think about rejection. So really, the take-home point here is that if you have any brady or tachyarrhythmia, which is symptomatic and sustained, you have to think about rejection. So, you have to rule that out. And, but if you have non-sustained episodes, watchful waiting is reasonable. So what about sudden cardiac death? This is the most common cause of, most common cardiac cause of death in patients with transplantation. About 25% of patients die with sudden cardiac death. Most of the times it is a late cause of death. The early cause from a cardiac cause with sudden cardiac death is usually due to non-specific graft failure. So you're looking at patients after 5 years or more close to 10 years who die sudden cardiac death due to allograft vasculopathy or chronic, antibody-mediated rejection. So now switching gears and going into immunosuppression. Obviously all the transplant patients are on immunosuppression, and really it is a constant balancing act between infection and rejection. So this is kind of an important slide for you guys to just look at to see that, initially the rejection episodes are very, very common in the first year. And then, this is, this is rejection and this is infection. So these two sort of, are much more in the first year, and then they kind of come, go down in terms of incidence. And then what really increases is malignancy and graft failure as you progress with heart transplant. So rejection, about 20 to 40% of patients experience acute cellular rejection. A lot of these patients can be asymptomatic because, again, like we discussed, they don't have innervation, and really to see cardiac-related symptoms is going to be minimal. So just there are two kinds of rejection. One is acute cellular rejection. The other one is antibody-mediated rejection. So what you will often hear are these grades of rejection. So when you're looking at cellular rejection, they are characterized by infiltration of lymphocytes in the cardiac tissue. So grade 1R, 2R, 3R, they all are based on the extent of infiltrate and myocyte damage. These can be associated with or without graft dysfunction. So a lot of times when we have rejection, we assess for intracardiac hemodynamics, looking at their wedge pressure, cardiac output, and also obtaining an echocardiogram at the same time to look at whether there has been a drop in LVEF, because this is going to significantly change how we manage these patients with if they have hemodynamic compromise or if they have a drop in ejection fraction, we take that a lot more seriously versus if you have just more of histologic grading without graft dysfunction. Again, this is grading of the antibody-mediated rejection. And the difference here is that the antibodies pretty much are related to perivascular infiltrates. And again, you look at capillary endothelial swelling and macrophage activation with myocyte necrosis. And here, you will hear often a staining called C4D staining, where you're really looking at staining for complement fragments, because most of the antibody-mediated rejection is due to complement activation and subsequent myocyte damage. So again, like we discussed, immunosuppression is a fine balance between infection and rejection. Although we all worry about rejection, really the most common cause of death in the first year is infection, as we saw in that slide. And sepsis causes approximately about 20% of all deaths in the first year. The big thing about infections in these patients is you really need to have a very, very low threshold for suspecting infection, because they are immunosuppressed and they are not going to mount a very big immune response. So they are not going to come with your classic signs of increased white count, fevers. Especially in things like acute abdomen, they can come with vague abdominal pain without any peritoneal signs, because if you don't have an increased white count, if you are not able to mount inflammatory response, they are not going to have an acute abdomen. So that you just have to have a very low threshold for suspecting infections. Again, this is a quick overview of looking at what kinds of infections are common in the in the time span. And as you get farther and farther from a transplant, more community-acquired infections are more. In the first year of transplant, because the immunosuppression is much more robust in trying to prevent rejection, you are going to see an increased risk in the first few months. And again, as you can see here, bacterial in the first 1 month or so with wound infection, catheter-related infections, pneumonia, and sort of the geographically restricted endemic fungi and all the rest of the viral infections and community-acquired infections after first year. So this is one of the major infections that we screen for very commonly because it has more than just an infectious problem in these patients, because it has a big bearing on whether they develop cardiac allograft vasculopathy, which we'll just touch upon a little bit later. So we routinely screen for CMV infections in these patients in the first year and subsequently. And a lot of times, these patients have vague symptoms or asymptomatic, mainly come in with flu-like symptoms and mononucleosis-like syndromes, and a lot of GI related symptoms. And we screen for this using CMV PCR and treat it even if they are vaguely symptomatic. So now I'm going to cardiac allograft vasculopathy. So let me just go to this slide first. So I just want to briefly go over how this is different from a native coronary atherosclerosis. So as you can see here, it's very focal, proximal, and usually eccentric lesions. And the pathophysiology behind having atherosclerosis is all due to lipid-laden macrophages, intimal injury, and then having plaques, which are very different compared to cardiac allograft vasculopathy, where it is fairly immune-mediated process, leading to more medial hypertrophy and very concentric lesions. So you get a lot of small vessel disease and more distal disease, which you really can't do much about in terms of PCI or surgical options. Again, cardiac allograft vasculopathy occurs in about 8% of patients during the first year and 32% of patients after 5 years. And it's a very, very challenging diagnosis to make because because it's very diffuse and it's distal, coronary arteriography is not very useful. Some centers use IVUS, but the problem with using IVUS and detecting it early is that we still don't have a good handle on what to do with these patients in terms of changing their immunosuppression. So again, early post-operative problems that you can get called for in these patients, RV failure, systemic vasodilation syndromes. Again, hyperacute rejection is very, very rare these days with our latest HLA techniques. Primary graft failure is really defined as, a graft failure with no real known cause, which means patients didn't have rejection, they didn't have, any vascular disease, but the graft failed. And bleeding and bradycardia, we went over bradycardia. Now, when you get called for a patient who is immediate post-op and has hypotension, if you're suspecting graft failure and your echo shows that the EF is suddenly low and the patient's hypotensive, if everything else fails, the first approach is to put a balloon pump in, but we have a very, very low threshold in, considering VA ECMO because a lot of these patients have reversible causes like, rejection, which we can treat and get them better and hopefully recover their cardiac function. Okay, so I think that was it. Thank you. Sorry for just rushing through some of the slides. I just had to.
No worries. Thank you, Ash.